Most welcome to our podcast, In the Loop. This is where we attempt to grapple with some of the fundamental issues and questions facing our health and care system. I'm Neil Dixon, former Chief Executive of the King's Fund and the General Medical Council, among other roles. My fellow presenter and inquisitor is the irrepressible Roy Lilly, whose regular emails attract many thousands and have become a running commentary on the NHS. Hello, Roy.
Neil, hello.
Our guest on this occasion is Lord Darzi. Ara Darzi is a dazzling surgeon with an exceptional reputation as a clinician, innovator and medical leader. When I was at the BBC in the early 2000s, we filmed him operating, and afterwards the anaesthetist approached me and said, "You've just seen a master at work. Ara is the most brilliant surgeon I and my colleagues have ever worked alongside." Ara's family background is Armenian. He was brought up in Iraq before the family left, fleeing as refugees in the 1970s. He trained in Ireland before moving to the UK, a professor at Imperial College and an honorary consultant at St Mary's Hospital in London. He's recognised internationally not only for his innovation and skill in the operating theatre, but for his research, his work on minimally invasive surgery and his ideas for reforming health services. Under New Labour, he was appointed as the National Advisor in Surgery, and he produced a groundbreaking report on London's NHS, which led to trauma, acute stroke and heart attack services being centralised in specialist units, a change that was then widely adopted across the NHS. One other proposed reform, the creation of larger so-called polyclinics to transform primary care, was not rolled out across the land. In 2007, the then Prime Minister Gordon Brown gave him a peerage and appointed him as a junior health minister, where he led a national review, High Quality Care for All, which the Financial Times described as the world's most ambitious attempt to raise the quality and effectiveness of an entire nation's healthcare. In 2019, he left the Labour Party and became a crossbencher as a result of what he saw as its failure to tackle anti-Semitism. Last year, the new Labour government asked him to lead an independent investigation into the performance of the NHS in England. His report concluded that the service was in a critical condition, with huge and growing waiting lists, poor cancer performance, and staff wasting time because of bed shortages and a lack of diagnostic facilities. He called for measures to improve productivity and move more care from hospitals to the community. The government recently launched its 10-year plan, Fit for the Future, which can be seen as its response to that review, with its three ambitions: to divert care from hospitals to community, from analogue to digital, and from sickness to prevention. And in the detail of the plan is a revival of Ara's earlier proposal to transform primary care with larger units staffed by teams from different professions. For anyone now leading change in the NHS, a key question must be around funding, with just 2.8% annual real terms growth promised over the next 3 years. That is around half the average growth per year in the 2000s, when Ara's last set of reforms were being introduced. Today, as his own review acknowledges, buildings, equipment and IT are in a dire state. Add to that low productivity, low morale, high sickness rates, dissatisfaction over pay and conditions, and concern about new roles, there must be questions as to how far the workforce will embrace these reforms, or whether self-interested conservatism will act as a barrier to radical change. Roy, what's your view of the challenges facing the government and the NHS leaders in taking forward Ara's ideas?
Well, I'm a big fan of Ara Darzi. I must say, I've known him for years, and he is a real innovator and a real leader. And when this last Darzi report came out, it was very critical of the NHS. There was nothing new in it. But what it did was it gave us license to be critical of the NHS. This actually said, you know what, these things are bad and these things do need to be sorted out. So it was a credentialing, really, of all of the complaints all in one place. And we had the authority of Darzi to say, you know what, we need to fix this stuff. But as you've just pointed out, the big issue now is how much of it who's going to do it, what's it going to cost, and when's it going to be done. That's the problem. It's easy to point out what's wrong. It's very hard to fix it and get it right. And I'm not sure Ara Darzi's report takes us into that territory. I think the so-called 10-year plan is a very confusing document, but I think we're in for a very confused period. But as I say, I'm a big fan of Ara Darzi, and I'm really looking forward to having a conversation with him.
Great stuff, Roy. Let's hear what Ara has to say. Ara, you are most welcome. Thank you for joining us. Perhaps you could begin by telling us how you went about this rapid review, which I think many of us feel may have a profound effect on the way the health service changes over the next 10 years.
Let me start with how it all happened. I got a phone call from the department to say, we would like you to do this piece of work. Then the request was to do something like this in 8 weeks. And obviously, new government, and I thought, be obliged to do something. And the only way you could do anything like that was to get access to the data, which is something I aspired to have as an academic, as a clinician, all my life. Now, obviously, all of us who worked in the National Health Service would have recognized some of the challenges. But when we did the analysis, I decided to go back in and say, well, these are the slides. There are 335 of them. And maybe you should release it to the public and let the people decide what's wrong with the NHS. And that's when the thing was thrown back at me. You know, most people wouldn't be reading slides, and we need a narrative. So the narrative was put together. So all of this was done in 8 weeks.
I think, Ara, the interesting thing about the report was there really wasn't anything in it that we didn't sort of know. You looked under the stones and you had the data and all the rest of it. But if you sit down with a cup of coffee with a nurse or a doctor, they'd all give you the same list of stuff that was just annoying them, not very good, dangerous, all that stuff. What I think the value of the report was that firstly is everything was in one place. And secondly, you gave license to people who had been critical of the NHS and been criticised for being critical, but you gave an endorsement to people working in the NHS and looking at the NHS to say, there it is. That was a huge value of what you did. Did you sense that?
Yes, I do. As I said to you, I did not know the depth of it. Things like productivity. You start believing the narrative. If you go back the last 3 or 4 years, the whole narrative, even since COVID, has been we're short of staff. And even in the Department of Surgery, we're saying we're short of staff, actually forgetting that half of us are sitting on a chair waiting for a bed to be available to start operating at midday rather than 9 a.m. in the morning or 8 o'clock in the morning. So that productivity figure, which should have been known, by the way, by the leadership within the National Health Service, that we have a serious crash of productivity, despite the huge incremental increase in funding to the NHS. That was a terrible story. And then, we picked up things like the midwives. Every midwife in the National Health Service is taking 4 weeks off sick leave, if you divide the number of sick days by the number of midwives we have. And the productivity of midwives was less than many of our European counterparts. There were a lot of new things that I came across, but, data doesn't lie. And it's not subjective, it's truly, truly objective.
I absolutely get it. I don't think anybody's challenged it, have they?
No.
It's one of the worst reports I've ever seen about the NHS. And I've seen a lot of reports. I've never seen anything so bad that was welcomed so enthusiastically. And then the next question is, okay, well, now what?
I was not sure how it's going to land. I had fears this could land very badly with the staff. I think some people did take it badly, but it wasn't the majority. Majority, actually, in fact, had the ammunition in supporting, at least the evidence is supporting what they've been talking about.
Just in terms of solutions, is it fair to say that the 10-year plan which you've been involved with does take forward the kind of reforms that you wanted to see? And I guess the ancillary question is, how confident are you that it'll do the trick?
Listen, I did a plan in 2008 called High Quality Care for All, which landed extremely well, thanks to you and Roy and many others who wrote very nice things about the plan, but it was never implemented. It's never the plan, it's the implementation, it's the leadership. At difficult times where the burden is huge and the money is tight, the art of implementation is the challenge that the NHS has faced for many, many years. And whether that implementation is top-down, whether it's bottom-up with some enabling tools from the top, which is really what High Quality Care for All was. On this occasion, I think there's a clear steer on innovations and technology. And, you're not going to find this as a surprise, someone like me, to talk about innovation and transformation, really. And so if I could talk to you about the future state, bringing it back to personalization, precision medicine, that's why the polygenic risk scores were there. Imagine what we can do if at birth we can actually stratify risk and intervene and manage at a much, much earlier stage. Imagine the potential of that in new drug discovery, pharmacogenetics. There was quite a big chunk about wearables and digital health technologies. We've been talking about this for 10 years. Question is, how do we make this happen? The technologies, the smartwatches that is looking at your oxygen saturation, looking at your ECG, digital biomarkers. We've talked about this before. We just have to make this happen. If we don't know how to make it happen, then we need to develop partnerships with organizations that provide this, these organizations that runs this in the private sector or in other sectors, in the banking sector. And how do we bring this all together? I think the biggest opportunity we have is AI. AI will leapfrog, will actually bridge the gap that we've had over the last decade. And it's quite interesting. If you look at the penetration of AI at a clinical level, a lot of clinicians are using it mostly in administrative side, which is really what takes most of your time, dictating letters, organizing tests, but also AI's transformational potential in preempting disease. It's not prevention, preemption. In other words, we're not talking about vaccines for measles here. We're talking about, from a polygenic risk score, capturing some behavioral attitudes, essentially detecting pre-disease states in which patients have no symptoms at all, and intervening at that stage. And I'm not talking about the common things that we screen for. I'm talking well and above and beyond that. And the AI mammography piece, which we did 4 or 5 years ago, what that showed is AI was able not to identify what a radiologist found. In actual fact, it goes 2 or 3 screening cycles prior to that, showing a lesion, which at the time was considered as normal. So there are huge opportunities here in preempting disease, preventing disease. The second is diagnostics. The biggest bottleneck we have in the National Health Service is diagnostics. We got through COVID with a simple diagnostic test. It wasn't the vaccine. Vaccine got us out of COVID. So we really need to invest in diagnostics, and we could develop many of these algorithms, by the way, in diagnostics. Most health systems are fragmented. They don't have very large data sets that you can actually do the machine learning component of that.
But the difficulty is, Ara, it's how.
Yeah.
How are we going to do that? And the document itself has over 20 key things that have got to be done and about 19 supplementary things that have got to be done. I mean, it is, in management terms, too much, too ambitious, and nobody really can get together their thoughts on how to do it. It would be such a shame to get this far and then watch it all just fizzle out.
I couldn't agree more with you. That's been a historical problem with the NHS. It's too big. It's too bureaucratic. It's too much top down. I think this will never happen if that's the way we're going to run this. The pull has to happen at a local level. We have to find ways of creating the pull. It's not financial, by the way. It's the opportunities in innovation and transformation that could actually release man hours, save significant amount of money, but more importantly to the patient, a significant amount of reduction in the amount wasted engaging with the National Health Service. It's all about new models of delivering care at your own home, in your community, an empowered patient. Again, by the way, I'm sure you're going to come back and say, we've heard this all before. We have. But that's the art of leadership and management. If you turn around and think about the stroke services, by the way, that also had huge negative press at the time, mostly from the hospital consultants, because we had 32 stroke centres in London. We were spending more than the whole of Sweden on stroke care, in London only. With the exception of 1 or 2, the majority of stroke centres in London were not meeting any of the international guidelines. And we ended up with a conclusion: we need 5 comprehensive stroke centres in London. And guess what? When you had the leadership ability of someone like Ruth Carnell, she made that happen. And guess what? This ended up being a Harvard Business School case study as an example of innovation and transformation. The safest place to have stroke was London. But more importantly, we then, if you look at the cost of stroke care in London, dramatically dropped. We were one of the cheapest capital cities providing stroke care and the best stroke care. So we've done this before. Similarly with trauma centres, there was only one trauma centre in London in 2006, and we ended up having 4 trauma centres in London, and that's another great example. So if there is alignment between the clinicians who believe in the evidence and the transformation with the leadership and management in coming together and really driving that change, it will happen. The idea it's going to happen from the 4th floor of Richmond House, it's not going to happen.
I want to go back to, first of all, funding, Ara, because during those earlier times which you've described, we had, on average, across those years, 5.6% every year in real terms. We're looking at 2.8% over the next 3 years. So the amount of funding is a lot less. The state of stress under which the health service is under now, given all the things that you described in your 2024 report, is much worse. The state of the buildings, the IT, everything else is not coping in a way that is worse than it would have been, say, certainly by 2005, 6, 7, where again, quite a lot of money had started to come into the service. And the staff are not in a happy place, as you rightly described. Levels of sickness are very high and so forth. So I guess my question is, yes, one accepts the idea that you need to have innovation at local level. It needs to be believed in by the clinicians and so forth. But how optimistic are you that the terrain is okay? And at the same time, we're engaging in a maybe absolutely rational, but a reorganization, which means lots of people are worried about their jobs and all the rest of it, and are seeing another initiative. We're moving on to a new world. And many people don't really understand, at least at this point, the narrative, the key leadership narrative, which is so vital to make this work.
I don't think the money is the issue here. I really don't. I think we've wasted a lot of money in the last decade and a half and more. I think the issue here is that of productivity. You're right, on the capital side, and we made that case very, very strong. And I wasn't aware of that. We do work in operating theatres where are well out of date. They should be decommissioned. We use equipment, but probably should be decommissioned as well. People were switching off their CT scanners in the weekend to save on maintenance money for these equipment in some hospitals. That's the type of information. So productivity has crashed in the NHS. So whatever money you're going to put into it, it's not going to work unless you address the serious challenge of productivity. It's not the revenue money I'm worried about, it's the capital investment. And that's the issue. We have completely starved the National Health Service of capital. And I had to tell someone quite senior when I presented this report, we need capital. And for some reason, we stopped investing capital. If you look at from the millennium to 2010, we spent 37.5 billion on capital in the NHS. And from 2010 to 2024, we spent somewhere around 2 and a bit billion. What was happening, the capital was essentially covering for the revenue losses at the time. So, how does capitalism work? Capitalism works because capital displaces labor. What's happened in the NHS the last 14 years? Labor has displaced capital because we've had a 20% rise in the FTEs we appoint. So a wonderful example of low productivity, and in many ways, you're not going to see the return on the investment. These are the big fundamental things. The productivity is one of them. Skilling the staff is another. Empowering the staff at a local level is another. Removing bureaucracy within the system is another. So I don't think this is a money problem. This is a cultural issue, giving the right people the right tool for the right reasons. AI will be one of the biggest investments we could make in capital to transform the whole system. On average, in an hour, 15 to 20% of a doctor's hour is taken out because of doing administrative tasks and functions in a clinic or whatever, and someone you never even find the notes. So the beauty about this report, we have the evidence of what's wrong with the NHS, which is sick. And if that's the illness, what do we need to do to fix it? And it can't be the same formula or the same prescription of the 2000, the millennium, the Tony Blair prescription. It wasn't the high quality of care prescription that I came up with at the time. And the reason I came out at the time, because we dealt with the quantitative burden, in other words, waiting list. I wanted to improve the qualitative side of the service. We then ended up in a 10 years in a very different place. Both quantitative and qualitative have been compromised. And we need that leadership at a national level and a local level.
Are you satisfied that there will be enough capital going forward? Because the figures don't look hugely generous in terms of the huge mountain of stuff that needs to be done, including, as you say, the hospital which I ran, where there was genuine concern that the air exchange systems we were operating with were ancient and there was a potential for them collapsing any minute.
The answer is no. I don't think we have enough capital in the National Health Service. And to be fair to our political leadership, they haven't figured out where the capital should come from. Capital investment from a Treasury perspective is a very different story. The 10 years of Brown and Blair, there was very clear capital strategy. That strategy needs to be redefined now because as it stands at the moment, we don't have it, which is one thing, but we don't have a plan for the capital. And that needs to be thought through. Capital markets are there. The global economy is not in a good place at the moment. So it's not just an issue within the United Kingdom, it's an issue on a global level. And we need to come up with another innovative business model in funding the capital, which is really what we did back in those days. If you remember, it wasn't just raising taxes. There are other ways of raising capital, which we have to think through. That's beyond my pay grade.
It's an interesting discussion. I mean, you look back on PFI, see the costs of that, and it's been eye-wateringly bad. There are things you can do. You could do a sovereign bond, but the Treasury, they say, no, that just adds to the national debt. Whichever way you look, you either end up with a variation of PFI, which I think most people will push against, or some other form of borrowing, call it what you like, and the Treasury don't want that either.
Could I add one thing before you move on? Capital will reduce the revenue expenditure we're doing at the moment. The duplication, the triplication is just phenomenal. If you want to improve productivity, you have to invest in capital, even at the expense of shifting revenue to capital. They need to relook at how we shift that.
I just wanted to talk to you about management for a moment. You made the point that the NHS was actually undermanaged. But here we are now where we're sacking half of the managers in ICBs. And there's a huge turmoil. I mean, I don't know how close you are to some of these ICBs, but I mean, it's a very bad place to work. I suppose you're going to say, well, AI and what have you could do a large part of the administrative work in the NHS. And then, we're back to capital. How do we pay for that and all the rest of it? I'd just be interested in your views of where managers will sit in this future.
If you're really looking at the burden of the challenges facing the National Health Service, what it needs is management and leadership. And I'm not stratifying this as being clinical and non-clinical. We need both, because without them, we're not going to have the transformative changes that we are aspiring to deliver in the 10-year plan. So management leadership is critical for this. And that's why earlier I used Ruth Carnell as an example. I couldn't have done that. She made the stroke services happen. And we need people like that who really have not just the leadership, but the oomph in really driving change and stop looking upwards, look in front, look towards the patient, look towards the providers. That's the type of leadership and management we need. At a national level, we need to enable and empower those leadership roles, whether clinician or clinician doesn't matter, and really driving that change locally. We've had few of those in the past, but we just need to nurture them. I mean, if you look at the gene pool of management and leadership in the National Health Service, it's there. We're not abnormal. We're not different than any other private sector, a GE or one of the big life sciences companies. It's the way we run it, the way we empower people at a local level, the way we give them the right tools, and the way we support them. That's the other thing about management.
How different do you think the roles of doctors, nurses and other professionals will be in this new digital age? And do you think they, and indeed their leaders, are aware and prepared for the very significant changes that lie ahead?
Majority of clinicians embrace innovation and know the consequences of innovation. Ultimately, you're improving the quality of life of the patient in front of you. But at the same time, the amazing innovations that we're talking about in front of us at the moment also could help completely transform the clinician's time. I mean, give me one example, and this may attract a bit of controversy. When we did the AI mammography paper, what that showed is that the AI was as good as the two radiologists reporting an image. And I could see the noise at the time because it was a displacement. And if you see it in that lens, you will say, oh my God, this is going to be displaced, it's going to create a lot of difficulties. I call it more augmented intelligence between a machine and a human. But instead of having two radiologists doing that, it was one radiologist doing that, plus the AI. I cannot predict the future. Maybe in 5 years' time, the AI will be as good and does it. Well, what do we do with this displacement? We've trained people, they've got their qualifications, they are competent clinicians. Could they become interventional radiologists? Because AI and imaging is shifting from surgical procedures to interventional radiological procedures. So that's the type of futuristic thinking that is not based on sexy tools. It's based on planning for your workforce and how you're going to commission that, how you're going to retrain some people. So AI will be embraced because it is so challenging delivering healthcare at the moment. So I am very, very hopeful. AI is able to come up with what we call pre-disease states. If you want the scientific word for it, it's called biodynamic shifts at a cellular level that we can predict where are they heading to. Dysplasia, cancer, neoplasia, whatever it happens to be. In diagnostics, AI being able to read your MRI within minutes. And, just imagine the productivity of that. And by the way, at the end of the day, a radiologist has to sign that off. Surgical practice, combine AI and robotics. We talk about robotics and precision, but if you add AI to that, in improving safety and efficacy of a procedure, AI and healthcare delivery, how could we target the populations at the greatest risk to really engage them in their illness or preventative tools, whatever it happens to be? AI could stratify that and also provide the opportunities of engaging those at the highest risk in getting into the trap of a pathway of care through the National Health Service. So I'm very optimistic about this. The only thing that I fear is that we may not do it at the same speed, considering every other system in the world loathe what we have, because we can do it faster and quicker than them.
A lot of people in acute care say, don't necessarily give us money. We need to get money in social care because this is a sclerotic system. We can't get patients who shouldn't be looked after in hospital out into the community. And the wrong patients are coming into us. Got the government's announcement of a review, but it's talking about a couple of years before its final report comes in. Do you share the ambition to get social care right, and how important do you think that is?
Social care has been the challenge for 2-3 decades. It transacts all political colours, and for whatever reason, we haven't yet had the leadership in saying we're going to bite this bullet. And it's not just dismal what it is at the moment, but the burden it's adding on the health service. So that needs to be fixed. You can't keep throwing that away because that's consuming a big chunk of the NHS's money. If you come up to an acute ward, you can see the consequences of poor provision of social care in the community impacting an acute surgical ward in a hospital.
If you could pick two things to do in the future, based on the theory that no organisation can do more than three things at once, what two things would you pick out of the sort of menu that we've now got in the 10-year plan and say, do you know what, the rest will be nice to do, but if we do these two things, that's really will be the big change we're looking for?
It's very difficult to say that, and you've got to bring your own biases into this as well. The big thing here is the capital side. If you really want to improve quality, productivity, safety, efficacy, we have to do something. We need to think about leapfrogging, not fixing what is broken, look completely beyond the bridge into the other side and think through what is feasible rather than fixing what is broken. If we don't have that appetite, that vision, that risk-taking opportunity, you're not going to close. There's a huge gap here. And I think the second will be, we are a sick nation. We have a system which is supposed to deliver a healthy nation. Public health is the motto. We have to empower public health, and I'm talking about contemporary public health now. With the tools of AI, data analytics, we could be stratifying risk, someone's postcode, intervening, helping them, get them to the next stage of their disease and intervene. So for me is the prevention is the public health. We should put a lot of effort into that and leadership. It's not the poor cousin that we talk about, proudly tell the Americans we have a single payer system. We do, but we don't know much with it. And then the second is the technological innovation ahead of us. If we don't exploit these now, we will never recover from where we are today.
And how optimistic are you that we are going to do that? Because they are really big challenges.
Well, I am optimistic. Let's focus on what matters: prevention and new technology to deal with the burden.
Ara, thank you. We'll have to come back and do part two, I think. It's so interesting to hear your perspectives and what you've done in your own career. So on behalf of all our listeners, thank you very much for giving us your time. And thank you for giving us reasons to be optimistic, which at this time is more and more important. So thank you for that.
Thank you. Thank you, Ara.
Thank you.
I don't know about you, Neil, but I mean, I'm a bit of a fanboy. I've got to admit, of Ara Darzi. I've known him for years, and whenever I'm with him, he always inspires me. So perhaps I'm not the one to do the objective appraisal of what we've just listened to. I mean, I thought he was very good. I thought he was very motivational, but of course, it still comes back. The practical bit in me says, fine. How the hell are we going to do it? Because he's talking about leadership in a context that, with the greatest of respect for all the people who are running the NHS, we don't have that inspirational leadership. Certainly, it's not coming from the top at a time when they're just busy smashing up the furniture and deciding where their offices are going to be. He is optimistic, but I am not optimistic. I think that's how it left me.
I think I'm nearer you than him on the optimism scale. I think there is potential to do exciting things. The bit I don't fully understand is how far the new technologies will change things. I think a lot, but also how quickly they can be brought in and how much they will deliver the productivity and the efficiency that he is ambitious about. And although he didn't really answer the question of, we've got 2.8% now compared with 5.6 across the new Labour years, so it's nothing like. But he did admit capital was an issue, which is a massive issue. And as far as I can see, the Treasury has not solved that issue. So he is going into this thing with one hand tied behind his back. All of them are. And as you rightly say, I'm quite in favour of dealing with the Lansley reforms and trying to get better, simpler systems and all the rest of it. But the danger is, as you and I have both pointed out, the disruption that will be caused around that. And the NHS, it's great at doing reorganisations, but it's also great at being completely distracted while it's doing them, and the effect on people's lives and so on. And social care, which, he said you've got to solve social care. But it'll need money as well as reorganisation. It's not going to be achieved just by, moving the deck chairs around again.
And the difficulty with money is, in fairness, more money has been put in, but it's been, to use Boris Johnson's expression, a lot of it's been spaffed because it's been used in emergency circumstances to buy our way out of trouble. We don't want money, we want investment. And that's the big thing. I mean, the AI, there's probably a revenue solution to that. Every time you use it, it's a ka-ching for somebody, so you could pay it out of the revenue budget rather than paying, capital for a license or something. I mean, there are ways around all of this, but whether or not the Treasury is up for it, and it's a very uncertain time. So I don't know. I'm going to go away and put a wet towel around my head and find out what I really do think.
All right. Well, thank you very much indeed to everybody. And thanks to you, Roy.
Cheers, Neil. Bye-bye now.